Okay, we have a case here to look at for immediate placement in site number 12. The tooth looks to have been broken down badly and decayed to the gum line. So I think it's pretty easy to see that this tooth should be coming out. Before we look at the implant, I do want to point out a couple of wonderful things here. The use of the findings feature for two items here. One, this mucus retention cyst or some type of sinus issue going on right here. And then two, for the periapical pathology found on tooth number 12. I would take this one step further. And one of the things we talk about in an implementation program is the use of the copy button. So by being able to come here, highlight this, go image, 2D screenshot, copy to clipboard, we're able now to paste this image, this particular section here, into our EagleSoft. And to make this a little bit better, what we could do is go ahead and use the various tools within the software here to get the most accurate image to allow us to see what's going on. And now we can clearly see this lesion right here. So just wanted to point that out to us. Now let's go ahead and focus in on the implant. So the big question here is on immediate placement. Based on a plan that we have here, a premolar, it is my intention to generally go with the 4.3 millimeter implant. Although the space may exist for a 5.0 implant as was initially planned here, what I have found in most people is that it gets too close to the root surface of the adjacent teeth. My preference is usually to try and go with a 4.3. The other particular reason, and we can go ahead and talk about this now on this one, is we will likely need to go to a 4.3 anyway, because what we can see right here is that our master cylinder is hitting the adjacent teeth. And we go to a 4.3, we can see that we also make the master cylinder smaller. So that would be another reason to go to a 4.3. Our ideal implant size in this particular site is going to be a 13 millimeter implant. If we continue to go with the 10 millimeter implant, one of the things that we can see here, and what I'm going to do is go ahead and turn on my drawing tablet, and we can see here is our bone right there, and here is our tooth, as broken as it may be, something like so. So we want the implant to apically engage or go beyond the tooth, and right now we don't have that. So we're really relying on mesiodistal and buccolingual bone, and right here, and looking at this, we have no buccolingual bone engagement from this view right here. So if we go ahead and take a look here, we can use the same technique here with our drawing pad, and I'll just draw the tooth. And I'm off a little bit right here. It's probably more along the lines of right there. And here we can see we have minimal engagement there and questionable engagement right there. So I would be concerned that this small of an implant will actually work. So I would like to see us go to a longer implant. Now in going to a longer implant, we bring the sinus into play. It may require a little bit of a sinus bump. It just kind of depends on the situation. I think the sinus is compromised in the fact that they have something going on there. But if we take a look at the opposite side, the patient has a pretty clear sinus on this side. So it's likely that this sinus issue is related in some way or form to either a tooth or just some type of retention cyst, as was noted, or is unlikely related to this tooth right here. As you can see, It just doesn't, unlikely related to that tooth. So we'll go back to our implant. So, I'm going to go with the 4.3 millimeter implant. Now let's go ahead and go through our checklist. 4.3, so mesiodistally, we're pretty darn close. If we look at this, we can see that we're more close to tooth number 13 than we are to tooth number 11. So we can tilt that just like so, and likely that's going to take care of that issue. Buccolingually, we're pretty good there. I want to come back to this area right here in a second. If we take a look at our vital structures, we are very close to the sinus. I'm not worried about this. Certainly what I would look at doing here is being very careful, maybe bumping up the sinus a little bit, take an osteotome, maybe a collagen plug, and placing that in there to kind of help protect the sinus. Now what I want to go through here is our occlusal table, and I'm going to make our implant disappear here for a second. So actually I'm going to put it back on. What I would like to do is again pull up my trusty drawing tool here, and we can say that this is the lingual outline, that is the buccal outline. Here's probably the central groove area about right here. So what we can see here is dead center would put the implant in about this spot. So we're a little to the lingual. Again, it may not matter, but as we're planning it, we want to be more ideal. So maybe we need to come out just like so. And that's probably a little more ideal. Great. Now the next thing we want to look at is our occlusal plane. And what we can see in looking at this is that our occlusal plane is probably a little more like that. So in an ideal world, we want to see this a little more flat. So what we would need to do that is tilt the implant like so, and you can see how that is correcting the occlusal plane. But the negative in that is now we're going to have an implant right up against this adjacent tooth. So in a case like this, this may be one of those situations where we simply have to leave it where it was and accept that compromise of being slightly offloading. So I'm okay with that, but I want to make sure that we make an attempt to get it more ideal. That's important, to always make that attempt to have it as ideal as possible. So there we go. Last thing I want to look at here is there is some question whether or not we're going to get engagement on this implant. There's no way of being able to determine that here. It's one of those situations where what I would do in my practice is I would go ahead and have the guide made, take the tooth out, advise the patient that we're going to make an attempt to place this implant, but we don't know until the day of, and then there's a chance that we'll need to graft the site and come back 4 months later. And in a situation like that, I would be able to use the same guide after we grafted. So what I would like to do is hide the implant, and I want to talk about one area here, and that is, will we need to flap this area? When I see an apical infection that's on the buccal, I become worried whether or not we need to flap that. And how I determine that is, one, if I'm going to put an implant here and this infection exists, which it does, you must clean this infection out. We cannot put an implant with that infection, that goober hanging out there. But the bigger question I have a concern about is right in here. Right there we can see what appears to be a break. Now it may not be there, but it appears to be there. So what I know on this particular case is that I'm going to need to flap this. Yeah, I'm just concerned that that buccal plate where the infection is very thin. There'll be a dehiscence there. So I would intend on flapping this case. So I would be prepared for that, to flap and to have to clean that out, to likely tear the periosteum from the goober that's going to be on there, to go ahead and pack some bone and maybe place likely place a membrane there to protect that bone from the torn periosteum, and be able to be ready to do that. So just be aware of that. So again, thank you for sending the case. Look forward to it.